All right, welcome back. In this final part of our series on sudden sensorineural hearing loss with vertigo, we're shifting our focus from the inner ear deep into the brainstem. Our first two explainers were all about spotting and treating what's usually a peripheral issue. But today, we're going to tackle the really high-stakes central mimics, the ones you absolutely must rule out. And then we'll get into the long-term rehab that truly defines your patient's recovery. So let's just jump right in.
So, picture this. A patient walks in with that classic story: sudden hearing loss, overwhelming vertigo. You do the hints exam and everything, I mean everything, is pointing to a simple peripheral cause, something like labyrinthitis. But then you spot it. Just a tiny flicker of facial weakness. So subtle, their own family didn't even pick it up. Right there, in that moment, the stakes are just massive. Because if you get this call wrong, you could be missing a stroke.
So here's our game plan for getting through this diagnostic minefield. First, we'll look beyond the periphery and focus on that great mimic, the AICA stroke. Then we'll cover why a scan for schwannoma is mandatory and do a quick review of other key causes. And finally, we'll pivot to the long game of rehabilitation and lock in the key takeaways from this entire series.
Right. So like we've said, the most common cause is peripheral. But now we have to face these central mimics. These are the diagnoses that are way less common, but infinitely more dangerous if we miss them.
And the number one offender, the primary diagnostic pitfall we absolutely have to steer clear of, is this one right here. A stroke in the anterior inferior cerebellar artery, the AICA, can look almost identical to labyrinthitis. And this isn't just an anecdote. It's a well-documented major source of missed strokes in the emergency department. Okay, so let's break down this great mimic. To really see through its disguise and avoid that diagnostic trap, we've got to start with the anatomy.
Now, what's so interesting here is the unique territory the AICI supplies. The absolute crucial part is that it gives off the labyrinthian artery, which is the only blood supply to the inner ear. But it also feeds parts of the brainstem, the lateral pons, and the cerebellum. It's this very specific vascular map that makes its clinical signature so unique, and honestly, so deceptive.
And this is the result. An AICA stroke knocks out the inner ear's blood supply, giving you that sudden hearing loss and vertigo. But because it's also hitting the pons and cerebellum, you can get these other signs, like same-sided facial weakness, sensory loss, or limb ataxia. The real trap is that the hearing loss and vertigo are often so dramatic, so loud, that these other more subtle neurological signs just get completely missed.
And here it is. This is the heart of the trap. Normally, with a central cause of vertigo, we expect a normal head impulse test, right? But with an AICA stroke, because that labyrinthine artery is involved, it actually causes an infarct in the inner ear. And that gives you an abnormal head impulse test, the classic sign of a peripheral problem. So you end up with a hints pattern that looks reassuringly peripheral, while the actual problem is a life-threatening central stroke. That is the critical point.
And this idea is so vital, it's really worth stating as a clinical rule you just have to burn into your memory. In a patient with just vertigo, a peripheral hints exam is pretty reassuring. But the moment that vertigo is combined with sudden hearing loss, a peripheral hints pattern is no longer reliable. It does not rule out an AICA stroke. You just can't be reassured by it.
Which leads us to this non-negotiable, definitive clinical rule. If your patient has that triad, sudden hearing loss, vertigo, and any vascular risk factors like hypertension, diabetes, or smoking, they need an MRI of the brain with diffusion-weighted imaging, period. It's mandatory, and it doesn't matter what the hints exam shows you.
Okay, so let's move on to our next must-not-miss diagnosis. Beyond stroke, there is another reason why imaging is so critical for these patients, the vestibular schwannoma. I want you to just look at this number for a second. 3 to 5%. For patients who come in with what just seems like idiopathic, run-of-the-mill sudden hearing loss, what do you think that number represents? Well, that's the percentage of cases where the underlying cause is actually a vestibular schwannoma, a benign tumor growing on the hearing and balance nerve. Now, it's not a stroke-level emergency, but it is a critical diagnosis to make. And this is exactly why an MRI of the internal auditory meatus with gadolinium contrast is considered mandatory for every single patient with sudden sensorineural hearing loss at some point in their workup. Now, besides AICA stroke and schwannoma, there are a few other culprits you got to keep on your radar. So let's do a quick fire round of this, let's call it a rogues gallery. Okay, autoimmune disease? You should be thinking about bilateral or sequential loss. Meningitis? Look for the red flags.
Fever, headache, a stiff neck. That's an emergency admission and a lumbar puncture, no questions asked. Ototoxicity? First thing you do is check their drug chart for any recent offending meds. And multiple sclerosis? You've got to consider it in a younger adult, especially if there are other weird neurological things going on. See? Each one has a pretty clear path forward.
Now, once that acute diagnosis is made and treatment has begun, our focus really has to shift. We have to move out of that emergency mindset and into the long game. And that means structured, long-term rehabilitation, which is what will ultimately determine their functional recovery.
The standard of care here means we have to track their hearing recovery over several months. That means scheduling structured audiology follow-ups at 1 month, 3 months, and 6 months to objectively see what's happening and guide what we do next.
And this is what that long-term strategy really looks like. It's a multi-pronged attack. You've got vestibular rehab to tackle any leftover imbalance. You've got hearing aids if the hearing loss is starting to affect their life. A lot of patients are going to need help with tinnitus. And so critically, we have to counsel every single patient on protecting their one remaining good ear from now on.
And I really want to pause on this point. Having some residual dizziness after one of these events is super common, but it is also highly treatable. Formal vestibular rehabilitation isn't just a nice to have, it is evidence-based. It measurably improves a patient's long-term balance and their ability to keep their vision stable when they're moving around. For their quality of life, it's an absolute game changer.
So, as we wrap up not just this explainer, but our entire 3-part series, let's distill everything we've talked about down to the most critical, practice-changing points. Let's think of these as 3 unbreakable rules.
Rule number 1, an AICI stroke can and will show up with a peripheral HENS exam. So any patient with sudden hearing loss, vertigo, and vascular risk factors gets an MRI DWI. Rule number 2, every single patient with SSNHL needs an MRI of their internal auditory meatus with contrast. That's how you're going to find the 3 to 5% with a vestibular schwannoma. And rule number 3, the job is not done in the ED. The long-term outcome is forged in rehabilitation and is defined by how well we help them protect their other ear. And that officially concludes our deep dive on sudden sensorineural hearing loss with vertigo. We've gone all the way from the first moment of recognition through that critical 72-hour treatment window and right to the end here, covering the central mimics and the long game of rehab. Thank you so much for joining us. To explore more topics on dizziness, vertigo, and imbalance, and to get access to a whole bunch of clinician and patient materials, please visit us at AustralianDizzinessClinics.com.